Welcome! Today, we are jumping right into a really complex and critical topic for any pharmacist, especially if you're gearing up for the PEBC MCQ exam, eating disorders. We're going to cut through the noise and focus on the high-yield clinical info you absolutely have to know. Okay, so here's our game plan. We're going to walk through this just like you would in a clinical setting. We'll start with classification and diagnosis, then we'll figure out our goals of therapy. After that, we'll do a deep dive into managing both anorexia and bulimia, and we'll wrap up with the really important considerations for special populations, specifically pregnancy and breastfeeding. All right, first things first, we have to build our foundation. And in clinical practice, that always starts with the official DSM-5 diagnostic criteria. This is the gold standard, so let's get familiar with it. So here are the core criteria for anorexia nervosa. You can think of these first three as the pillars of the diagnosis, right? You've got the restriction of energy leading to low body weight, this intense, persistent fear of gaining weight, and a distorted view of one's own body. Now, for your exam, pay close attention to the severity levels based on BMI. You've got to know these specific thresholds. Differentiating between mild, moderate, severe, and extreme is a classic high-yield point. Now let's shift to bulimia nervosa. The key feature here is this really destructive cycle. It starts with recurrent binge eating, often with a feeling of being totally out of control. And that's followed by some kind of compensatory behavior, like purging, to prevent weight gain. The key detail for diagnosis, this cycle has to happen at least once a week for 3 months. And here's a crucial difference from anorexia. Severity is not based on BMI. It's based on how often the compensatory behaviors are happening each week. Taking a thorough history is absolutely foundational. As pharmacists, we have to know what to ask and what to listen for. So beyond just eating habits, we have to screen for physical symptoms. Are they getting chest pain or palpitations, dizziness? These aren't just symptoms. They're huge red flags for dangerous electrolyte imbalances or even cardiac issues. And we always have to screen for psychiatric comorbidities like depression and anxiety because they're incredibly common and will directly shape our treatment plan. The physical exam can tell a really powerful story, and it can reveal signs that are classic exam questions. The most famous one is probably Russell's sign, those calluses or scars on the knuckles from self-induced vomiting. In severe cases of malnutrition from anorexia, you're looking for things like postural hypotension. You might also see something called lanugo. It's this fine, downy body hair that the body grows trying to stay warm when it doesn't have enough body fat. Now, what's really interesting here is seeing the lab work side by side. You can see there's a big overlap, especially with electrolytes, which makes sense given the risk of purging and dehydration. But notice that specific checkmark for an ECG in anorexia nervosa. That's critical. Why? Because severe malnutrition and those wild electrolyte swings can pose a major risk to the heart, things like arrhythmias. So, we know how to diagnose and investigate. The next logical step is to figure out our goals. What are we actually trying to accomplish with our treatment plan? Understanding this why is so important before we get to the how. As you can see, the goals here are incredibly multifaceted. This isn't just about weight. Sure, restoring a healthy BMI is a primary goal in anorexia, but for both disorders, we have to treat the whole person. That means stopping the binge purge cycles, treating the physical damage from malnutrition like osteoporosis, and crucially, addressing the underlying psychological drivers like depression and anxiety. The end game is full recovery, restoring function, building healthy habits, and of course, preventing a relapse. Okay, with those goals in mind, let's zoom in on how we manage anorexia nervosa, and the absolute foundation of any treatment plan here, where it all begins, is with non-pharmacologic strategies. Particularly for younger patients, for adolescents, family-based therapy isn't just an option, it's often the single most effective approach. The Maudsley method is a key evidence-based model here. It works by empowering the family, first by educating them, then by actively training them to take charge of meals and support their child, creating a system for long-term recovery at home. These non-pharm interventions are the true cornerstone of treatment. The focus is all about setting realistic nutritional goals to restore body fat. And it's really important to remember this. Psychological treatments often just can't work until the brain has the energy it needs to function properly. That energy comes from this nutritional restoration. Even simple things like a warm room can make a difference by reducing anxiety. So malnutrition can slow down the entire GI tract, meaning gastroparesis or delayed stomach emptying is a really common problem in anorexia. To manage it, we use prokinetics. Now, from a pharmacy perspective, this comparison is key. Domperidone is often preferred because it doesn't cross the blood-brain barrier as easily, so you get a lower risk of those extrapyramidal side effects. But, and this is a big but for your exam, the major red flag for both agents is the risk of QTC prolongation. you have to remember the need for ECG monitoring. And this table is a fantastic summary of how medications are used in a targeted, supportive role for anorexia. Notice, none of these are curing the disorder. Instead, we're using things like prucalopride for constipation, olanzapine to help with the obsessive thoughts about food and improve motivation for weight gain, and quetiapine for severe anxiety. And this last one is critical. Thiamine must be given at the start of refeeding as a prophylactic measure to prevent the devastating Wernicke-Korsakoff syndrome. This is a life-threatening emergency, and every single pharmacist has to be aware of it. Refeeding syndrome happens when a severely malnourished person is refed too quickly. That sudden flood of carbs causes a huge insulin surge, which drives phosphate from the blood into the cells to make energy. This rapid shift leads to the hallmark sign, severe hypophosphatemia, and that is why refeeding must always be done slowly and carefully by an experienced clinical team. All right, time to switch gears and talk about bulimia nervosa. Now, while it's related to anorexia, the underlying issues are different, which means our therapeutic approach has to be different too. Here, our primary target is breaking that binge-purge cycle. This slide highlights a fundamental difference that you absolutely need to get for your exam. In anorexia, remember, meds are supportive players. They help with symptoms. But in bulimia, pharmacotherapy, specifically antidepressants, can actually be a primary treatment used to directly target and reduce the frequency of the binging and purging. Just like with anorexia, therapy is the key to long-term success. For bulimia, cognitive behavioral therapy, or CBT, is a first-line treatment. It's designed to help patients recognize and untangle those distorted thoughts and beliefs that fuel the cycle, and then replace them with healthier coping skills. Other important tools in the box are interpersonal therapy and guided self-help programs. When it comes to meds for bulimia, antidepressants are the mainstay. SSRIs, especially fluoxetine, have the best evidence behind them for reducing binge-eating episodes. But the single most critical point on the slide, and a classic exam question, is that contraindication. Bupropion is an absolute no-go. It must be avoided in patients with eating disorders because it's associated with an increased risk of seizures in this population. You must know this. Now this is a crucial pharmaceutical care point. If you have a patient with bulimia who isn't responding to their antidepressant, your first thought shouldn't be, oh, the treatment failed. Your first thought should be about absorption. You have to ask about the timing. When do they take their medication, and when does the purging happen? Is the pill even staying in their system long enough to get absorbed? This simple question is often the key to solving the problem. All right, finally, let's talk about two special populations where management gets even more complex: pregnancy and breastfeeding. This is an area that requires a really careful risk-benefit analysis and a strong multidisciplinary team. An active eating disorder during pregnancy automatically means it's a high-risk situation, and it's a bit of a toss-up. While symptoms can improve for some, they can also get much worse for others, which creates significant risks: miscarriage, low birth weight, and other serious complications for both mom and baby. The approach has to be super cautious. You reassess every single medication, you prioritize non-drug strategies, and you make sure a dietitian is closely involved to manage nutrition. And what about breastfeeding? Well, while severe malnutrition can definitely impact milk production, the good news is that with the right support, most patients can breastfeed successfully. The key, once again, is a strong partnership with a dietitian. And for us as pharmacists, our role is crystal clear. We have to diligently check every single medication against specialized references to ensure it's safe for the infant. So let's end with a clinical scenario to pull this all together. You've got a pregnant patient with a history of bulimia. She's on fluoxetine, and she tells you her purging behavior has increased. What is your number one immediate clinical concern? Think about electrolytes, fetal health, drug absorption, all of it. What's your primary recommendation? This scenario forces you to integrate everything we've just covered. Use it to test yourself and really solidify your learning.